Good afternoon, everyone. It's not this one, please. Excuse me, can you show my presentation, please?
Reem, can we put the slides?
This one, the
Where are
third
they?
one.
Yeah. There we go.
Again, good afternoon, everyone. Sorry for the sake of time. I will try to go fast. Our patient, 67-year male, diabetic, hypertensive, chronic kidney disease, ischemic heart disease, status post-cabbage 10 years back, with coronary angio 3 years back, showed patent hematology, mild disease in RCA with occluded graft OM, diffuse disease for medical therapy of the native circ. AF unwatchment defiles due to frequent upper GI bleeding. Patient with frequent admission as pulmonary edema. The most positive finding in examination, he's conscious oriented with good functional capacity, chest crepitation, ascites, lower limb edema between ACG, AF with heart rate around 90. In the transthoracic echo, ejection fraction 35%, dilated LA-RA-RV, mitral valve sclerotic leaflet with 2/3 both leaflet with severe MR, tricuspid normal morphology, malcoaptation, and severe functionality R, pulmonary artery pressure 61. So this is the TE of our patient, showing long anterior leaflet, short posterior leaflet, and degenerative change. This is modified by caval view, showing dilated RV, dilated RA, again. Okay, severe MR in intercommercial and LVOT showing it's in the A2B2 area. Again, in the intercommercial view, and explain on that to see the LVOT, the same finding, long anterior mobile leaflet, short posterior, short mobile posterior segment with the severe MR. The initial main pressure gradient was 4, and the mobile part of the posterior segment, it's 0.921. Area, it's borderline, 3.9. Severe functional TR, to begin with that. So now, what is the best treatment plan for this patient?
So we have now a question like, so Zakaria, what is your thought? Can we go to the smart screen, please? Should we go with just send the patient for surgery, or go for clip, or should we go for both clips, TEER in the tricuspid and the mitral, or just keep the patient on medical therapy?
I think we have vote for that.
Yeah, we have a vote for that, yes. So can we have the vote or the smart screens first, for the interest of time? Yalla. Smart screen, please.
So, patient has ischemic heart disease, post-cabbage, ejection fraction of 35%. The provided images, I was not able to decide where is the regionality, but I would assume it is the LAD area.
It was 30 to 35. Global hypokinesia.
Global,
yeah.
Okay. And there is severe MR with the restricted posterior mitral valve leaflet short. It was 8 millimeter. And the mitral valve gradient is 4. Do you have any idea about the mitral valve area?
3.9.
So the gradient is 4, and the area is 3.9. So this will put us in, I would say, not the red zone, but it will be in the orange zone for mitral valve percutaneous edge-to-edge repair, because the area is less than 4. The posterior leaflet is 8 millimeters, so it's a bit short. And it would be, we will expect a higher gradient also, because the initial gradient is 4 as well.
Okay, so what did you do? Back to the slides, please.
Okay, so symptomatic patients, syphilis symptomatic with frequent admission as pulmonary edema with this difficult anatomy, as a heart team meeting and patient, after thoroughly discussion, we decide to go for mitral clip. This is our, during our procedure, after puncture. This is a guide in 3D in LA. We are adjusting our clip in
So
both...
what clip you decided in terms of the sizing? XT, NT?
XTW, yeah.
You went with an
Decide to go-
XTW?
Yes.
Okay, keep going.
Due to, it is difficult to choose which of which, but we have a long anterior leaflet, mobile one, so we decide to go for XW and to see what will happen after that.
I think the posterior was 0.9 or so lengthwise, so.
Okay, this is our grasping zone, 3D to check for our perpendicularity. We start to grasp our leaflet valve. This is after grasping, it's showing good reduction of MR, or excellent reduction of MR, grasping all the anterior and posterior. This is the surprise, the ejection, the gradient went to 10, a small area. So now, patient with excellent reduction of MR, but with high mitral valve gradient. What's now?
So either we accept the results and we conclude the case, or we change the clip to a smaller one, or we abort the case and just go with maximum NS, and then I would hear from Dr. McKenzie.
Gradient of 10 generally, to me, is not considered acceptable, so I would definitely not take this result. Usually, we have to remember that the patient, when they are off anesthesia, their gradient would go up by at least a couple of points. Usually, maybe my upper limit of, comfort zone is around, 5 to 6, maybe 6 millimeters of mercury is the maximum that I would accept. Maybe in an older, less mobile patient, that would be a more of an acceptable gradient entry. So I would go with a smaller clip. Try maybe an NTW or something like that. Yeah.
Dr. McKenzie?
Yeah, I would second that, and then also express my surprise that you used an XTW to begin with. We find in the functional, and this may be a little bit of a mixed picture between functional secondary MR from a ventricular dilation and annular dilation. In addition, there was AFib, so there's a large atrium. There's probably an atrial MR as component as well, which often we find more shallow leaflets. The tenting angles are a little different, or tethering is not as pronounced. And with a short leaflet of 9 millimeter, perhaps an NTW would have been a good choice. The other key element is the heart rate, which seemed to be quite fast still when you did your mitral gradient assessment.
Back to the slides, please.
So if you allow me, on this I have 3 points. One is the short posterior leaflet. It's 8 millimeter. So we need for XCW at least 9 millimeter of the posterior mitral valve leaflet. Now the second is the rheumatic changes, which is common here in our area. There might be some subtle rheumatic changes that might missed during the evaluation of the mitral valve. Let's say a minimal changes. The third point, which is sometimes difficult to assess by echo, is the stiffness of the leaflets. This terminology is always said, but personally, I have no clue how to assess it. Sometimes the leaflet looks mobile, the area is good, the gradient is reasonable, but whenever you grasp, you will have jump of the gradient, probably because the leaflet itself, it's stiff, let's say, it's fibrotic. I'm not sure if other modalities like MRI can help us in assessing this point in the future.
Okay, back to the slides, please. Let's see the conclusion of the case. Dr.
Okay, our
Al-Shehri.
decision at that time to go for changing the clip size with smaller one. So we went to NT, and then we'll decide to have another one or to accept the results, as it's difficult anatomy with young patient. Can we move to the next, please?
Next slide, please. Technical support, please. Next slide. The next slide.
Next, please. It's not moving from.
Could you go to the presentation, please?
Okay, again.
So if you can see the final results, Ya Abdullah, move for the interest of time. Mashiha.
Okay. So this is the MR after NT single clip. It's reduction of the MR about 50 to 60%. Again, please, this is the last slide.
So we had what is the final one? Final results?
Okay, the final
Gradient
result
and
was
follow-up?
Fisher gradient was, we end with 6, reduction of MR about 60%. Next, please. There is no reversal. This is the most important. Yeah.
How did the patient do in follow-up?
Yeah, okay. And next day, metavalve gradient was 7 at heart rate of 120. In follow-up after 2 months, patient doing well, improved quality of life, no more admission as pulmonary edema.
Okay, so the moral of the story, pick and choose your tool before proceeding with the case. Maybe if you have went with an NT from the beginning would have been better, and controlling medical therapy. So thank you, Dr. Abdullah, for the insightful case. Without any further ado, last but not least, Dr. Bandar AlShehri, please. Could we put the slides of Dr. Bandar AlShehri, please? And while we do that, Dr.
So a few points about selection of the device. What makes you select the device is the length of the posterior mitral valve leaflet. It will decide whether it is NT or XT. And then the wide width of the jet. The wider the jet, the more you should go to the W. If it is narrow jet, then you can go with the regular, device.
Okay, Dr. Terry?
Then just one point more is the other, let's say, device available in the market, which is the Pascal, which we have P10, and the Pascal ACE, which the ACE is it's equal to XTW output mitral clip.
So for the interest of this time, and we are very sorry, we have to move on. We have lots of questions, but Dr. Terena, could you introduce Dr. Bandar?
Yes, Dr. Bandar AlShehri is a consultant of structural and congenital interventional cardiology at Prince Sultan Cardiac Center, and he's going to be talking to us when the leaflet is the cause.
Okay, hello everyone. Thank you very much for giving me the chance to present my case with the title, When the Leaflet is the Cause. So I will go quickly through the history and the physical examination. My patient is a 60-year-old female. She is status post-aortic valve replacement, and with the cabbage 2 graft to the LAD and the RCA. The patient actually demonstrated stable recovery, but after that she developed significant shortness of breath, required multiple furosemide doses, significantly increasing over the past 8 months, and almost 2 months now she requires more than 40 milligrams of furosemide TID. This is her past medical history, medication, and allergy. So regarding her physical examination was unremarkable. The coronary angiogram showed patent graft, and this is her transthoracic echo.
So can you let it run, and we can have the insight of our imaging here.
Let's hear from Dr. Zakaria.
Yeah.
Okay.
Yeah, next.
Sure. You can see on the echo that there is severe or significant mitral regurgitation that's quite eccentric going posteriorly. You can interestingly see that the flow acceleration is at the LVOT, almost at the body of the base of the anterior mitral valve leaflet.
Okay. So, and this is the transesophageal echo. And so this is exactly. Yeah. Go ahead, Dr. Moore.
Yeah, so basically, as you can see, similar to the transthoracic echo, you can see that the flow acceleration from the LVOT at the base of the anterior leaflet, again, indicating probably a defect of the body. And you can see a 2D defect on the right-sided image over there, indicating a perforated body of the anterior mitral valve leaflet.
And this is the 3D, the transesophageal.
So the anterior leaflet is at the top of
Can
the
you
screen.
point out
You can see a couple of holes there. Yeah.
Yes,
Yeah.
exactly.
Okay.
Yeah.
So as you see here in the 3D, there is a circular defect of the anterior leaflet clearly at the basal of the A2. So the case was discussed in the combined meeting. We offered for the patient the choice for the surgery, but you know, most of the patients, if they try it once, they will never think about it again. So we decided to proceed with percutaneous intervention. So which approach will you choose for the percutaneous closure of the perforated anterior leaflet?
Can we have the smart screen, please?
I don't think anybody's done this to.
So, yeah, so Zakaria will
To
tell
have
us the
an
options. So we have three options, Zakaria. What is the first option, Bandar?
Okay, so we have retrograde transfemoral approach, retrograde transapical approach, and antegrade transseptal approach, or you will tell your patient that there is no choice other than surgical approach.
So first approach, Zakaria, how is it? Just can you elaborate?
So from the retrograde femoral approach, so you have to cross the prosthetic valve and go to the LV from the aorta, coming from the aorta to the prosthetic valve, go into the LV and cross the mitral valve. The apical approach should go through the apex, and this will require thoracotomy, and then cross the mitral valve, the lesion. And the transseptal, it's clearly like what we are doing in the mitral clip and percutaneous steer, is to go through the transseptal, go to the LA, and then cross through the lesion and go to the aorta.
I would like to hear from Dr. Adel Tash. What do you think with our crazy approaches from the intervention side? What you will tell us, don't do it, or
I would add one more approach, which is the tendine.
the tendine. So tendine is an option still, but though it's a transapical. Dr. Fahad, any thoughts? Just
So,
crazy stuff,
Yeah,
huh?
I will treat it as any BVL, go transseptal, then cross and close it as a BVL. It's behaved like BVL. The problem is you probably need like an anchoring wire, just in case you need to test multiple times and see the best device and make sure there's no severe MR after you close it. So I think will be multiple attempts.
But
just
it's
to
not a
make sure.
PVL, right? It's actually in the leaflet.
It's
So
a
you're
perforation in the
you don't know what the leaflet is gonna do after
Yeah.
you put a device there.
Dr. McKenzie, you've seen crazy stuff. What do you think?
We've done this actually quite a few times, and last year I was privileged to be part of a life case that Horst Siever did doing CSI in Frankfurt, and with, again, a good result. The key is to find an occluder device that's flat enough, because you're sitting right in the LVOT, and if it reaches in, you can have hemolysis, you can have flow disturbances. It's really important to select the right device. What I like here in this situation, it looks like the stable position in the aortomitral curtain, or just outside of the aortomitral curtain, and looks like a well-defined circular hole, which likely will be a good landing
Let's have
zone.
the slides again, please.
And one more thing, I think if we do also CT scan just to see the shape of the shape of the hole and measure it, I think the most important thing is not just crossing, it's just the device selection. I don't know what kind of device will fit this. Probably multiple attempts to see.
Okay, so tell us what happened next, Bandar.
Okay, so do you have the slide? Okay, so my approach was to proceed with antegrade transseptal approach. It was TE guide transseptal puncture. And as you see here in this 3D transesophageal echo, that our Agilis catheter in the left atrium, and we have 4 French catheter, glide catheter. It is angle tip catheter, can be directed exactly to the opening, which need to be crossed. And I want to advise everyone, if you are trying to do the mitral case, especially in the paravalvular leak, to go directly with Agilis catheter. It will be very difficult without it. And then after that, we cross with the glide wire, hydrophilic wire, the hole. Then we send it to the aorta. And actually, we are using most of the time glide catheter, which is 4 French glide catheter. It will follow your wire. So this is very helpful in the paravalvular leak, and this is what we did exactly. And after that, we crossed with our stiff wire to the aorta.
What kind of stiff wire have you used there?
Yeah, actually we used Amplast extra stiff wire, straight. You can create like small angle on this wire, so to cross it. Because if you use curved wire, like the Safari wire or Confida wire, most of the time it will take you out from the catheter. It will go out from the leak. So this is my advice, to go with a straight wire with small angle tip. So after that, this is the transesophageal echo, which shows clearly that the wire going from the left atrium through the hole to the aorta. And after that, we brought our delivery sheath to the aorta. And this is clearly in the transesophageal echo that the delivery sheath is crossing the hole. After that, the decision now, which closure device will you choose? Will
So
you go with...
I may stop you here. So we have multiple devices. Could you have the smart screen, please? So tell us, Bandar, what's the difference between all
Yeah.
these devices?
Yeah, sure. Number one, all these devices was created for other indication. The only one which created only for the paravalvular leak, which is around the valve, is the occlutic paravalvular leak closure device. The ASD, it is 2-disc device with a good waist. The unplastered ductal occluder, there is a good waist. It is only one single disc. The unplastered ductal occluder type 2 is 2-disc. There is a waist, but actually the largest height was 7 millimeter, and our defect is almost more than 8 millimeter. The unplastered vascular plug, which usually we are using it for the paravalvular leak, and especially in the eccentric shape paravalvular leak. And this is the shape of the devices. So for the sake of the time, we decide to go with the ASD closure device, since we have like 2 discs, which can help you to stabilize the device in the leaflet.
Could you point out the device that you choose?
Yeah.
Because some of us are not
This
familiar
is
with the
A-
devices.
yeah.
Which one? With
This
your
is the
cursor?
ASD device, and this is the shape. There is 2 discs, and there is a waist which can occlude the defect.
Okay.
And this is the occlutic paravalvular leak occluder. There is 2 design. There is a square one, and there is rectangular one. And also for the waist, there is like significant waist or the twist. The twist usually to use for the leak, which is have small hole, while the waist, this is for the significant leak. And this is the case, as Doctor mentioned, the case which was presented at the CSI, they used the occlutic paravalvular leak occluder, but it was not available during our case. So as you see here, we open the first left disc in the LV, and slowly we are retracting it. And you have to be very careful, because we know
Can
that
you
the
point it out, Bandar? Give us 2 minutes extra. And point out with the cursor on the disc, the one from the...
Yeah, sure.
Play it, please.
Okay, so this is a disc, as you see it here. And it will be very clear in the transesophageal echo. As you see here that we are open the first disc, the left disc, against the base of the anterior leaflet, and slowly we are releasing the second disc. So this is after releasing the second disc. As you see, there is significant intrinsic MR. So we thought during that time that this is most likely it is related from the tension which was created by our delivery and the wire. So we decide to release it. So this is after the releasing of the device. As you see here, the device takes the shape of the leaflet. It is away from the tip of the leaflet. And this is very important, because this is what can create the gradient after the release of the device. And also there is no any significant MR. And there is, from the beginning, there is mild intrinsic MR, which is the same like now. And this is the 3D. And the transthoracic echo next day, which showed freely mobile anterior leaflet. There is no any significant LVOT obstruction. There is no significant on the gradient of the mitral valve. So in conclusion, percutaneous closure of the anterior mitral leaflet perforation is visible in selected patient as center with experience in structural heart disease. You have to understand exactly what pathology you are treating. What is the shape of the defect? It is oval, is it oval? Is it circular? Is it eccentric? Because each defect have its unique closure device which you need to use it. And also you have to know exactly what is the disc, what is the size of the disc, and how much it will be far from the tip of the leaflet, because this can create the gradient. So this type of the cases need to be studied very well, and we can have like a good outcome like this patient. This patient had been seen in our clinic 6 months after the procedure with significant improvement in her symptoms. She was doing great. And also I went back to the literature. Dr. Abu al-Ada also, he published one of his cases was following his patient for almost 2 years, and she was doing great. Thank you very much.
Thank you, Dr. Bandar. Amazing.